So thank you for having me today. It's an incredible pleasure to be here in this incredibly beautiful country, talking about the work Australia has done copying Canada's homework. So I'm introducing a project that was originally developed in Canada, and I'm here this weekend to deliver training on the HIV Peer Navigation approach, which we've adapted in the Australian way and claimed as our own. So really all credit here is due to the Canadian originators of this approach. My slides are almost ready. I should note that I've had about 6 shots of coffee today, and they're countering the jet lag that I'm otherwise experiencing, so we might actually get to finish on time. And yep. And so the topic of today's talk is HIV peer navigation. What are we navigating? I really want to talk to you about the systems that community peer navigators are engaging with. The community system, the healthcare system, and the policy system. I acknowledge and pay my respects to the Gadigal people of the Eora Nation in Australia, who are the traditional owners of the land on which I live and work, and I acknowledge the Maori people of Aotearoa, the ongoing importance especially of the Treaty of Waitangi. We don't have treaty in Australia, and it shows up in every aspect of our society and our culture. I also want to acknowledge the people living with HIV who participated in research that established the approaches that I'm going to be talking about today. About me, these are a couple of papers, a paper and a poster. I'm a queer and non-binary person with disability. I've been working in HIV for 20 years, mostly in HIV-positive health promotion. I'm the Senior Project Officer with the NAPWHA Learning Initiative, and I have 2 disclosures. My projects are funded by ViiV and by Gilead. Talking very quickly about what I'm going to cover, a bit of background, but I'm going to focus on the definition of the approach. What are we navigating? How are we navigating it? And if we have time, some essential skills, clinical integration, and learning and advocacy. So some background. HIV peer navigation is seen as an exciting new approach, the new kid on the block, but HIV was actually quite late to the party. It starts with the South American promotoras movement from the 1970s onwards. There were lay health navigators adopted in the United States in the 1990s, particularly around cancer. And that was where a lot of the research was conducted that showed that this approach actually works and contributes to improved health outcomes. CATI, the Canadian AIDS Treatment Information Exchange, released these marvellous guidelines on the peer navigation approach in 2018. It was adopted in Australia around the same time, and Australia put out the HIV peer support standards in 2020. Oops, I've gone backwards. So these are the 2 kind of key guidelines that I want to draw your attention to. CATI on the left, peer support standards in Australia on the right. I'll start with the peer support standards because they're simpler. They call for 4 things: that all people with HIV have access to HIV peer navigation, that there is proper and appropriate support for the people doing the work of peer navigation, that we have rigorous and robust monitoring and evaluation approaches, and lastly, that peer navigation services are not seen as a standardised approach, that they are in all cases adapted in response to the needs of the communities that they are working with. Now, CATI 2018 is a much more rigorous and in-depth set of guidelines. I really strongly recommend them to you. They cover infrastructure assessment, defining the scope of practice, ethics, recruitment, selection, compensation, supervision and support, training, monitoring, evaluation, clinical integration and community engagement. Right? So this is a great document if you're having trouble getting to sleep at night, and then when you wake up in the morning after fantastic dreams about peer navigation, then you can go back to it and learn, right? These are the absolute mandatory requirements for a program of this type. So I'm going to present the Australian definition that we've worked out. And this definition draws quite heavily on the work of my colleague, Dr. Tim Krulik from the Australian Research Centre in Sex, Health and Society. We define it as peer navigators use their lived experience, interpersonal skills and workplace training to enable other people with HIV to make the most of the clinical and social care and supports available to them. This is a reasonably simple definition, but there's a surprising amount of information packed into it. A peer navigator must be a person living with HIV. They must have strongly developed interpersonal skills. They must have what the W3 project called peer skill, the ability to use their lived experience to connect with other people. They must receive training, supervision and support. They engage with clinical and social systems, and I'm going to show you what that means in a minute. They respond to their local environment and they focus on maximising benefit to the client. So let's talk now about some different ways of showing you what it is that peer navigators are actually navigating. This is a mind map of the different services that are available in the Australian context, and this is based on survey data that I conducted about 2 years ago, and then in preparation for today I analysed them in a huge hurry. Don't worry if you can't see what's on screen. There are HIV clinical services, there are non-clinical services. There are social support services, there's community services, there's representation, there's legal and financial services, and I think I've covered that. There are QR codes on all of these slides if you want to grab out your phone, and this presentation is available from me or from Mark or Ron afterwards if you want to have a closer look at what these maps actually show you. So that's, oh, hang on. Now, there are lines connecting these different kinds of services, but what I want to draw attention to is the gaps. The gaps between these services are particularly important. They're just as important as the linkages. They signal that there is a huge diversity of needs that are being met by services that don't typically work together. So these are all discrete services that are doing their own thing, and they're not necessarily connecting up with other services to understand how could we be working together. And that is a huge problem because the problems that peer navigation clients face often gang up, right? They group together. Very rarely would a peer navigator see a client who only has one problem. It's very common for them to be facing multiple challenges that intersect, interact, and reinforce each other. So peer navigators, a key aspect of what they're doing is supporting clients to build the skills they need to bridge the different services that are available to them and to patchwork together these different discrete services across multiple occasions of care. So what's the point of all of this? Now this is the AusQual framework. AusQual we borrowed from PosQual, slightly cheeky gloss on words, sorry Graham. It's the Australian Community Accord on Quality of Life, and it's a framework of 4 positive determinants and 4 negative determinants of quality of life. The positive ones are in a lovely shade of pink. They're care, meaning, belonging, and support. And the negative ones are in also, I think, kind of a nice shade of purple. Insecurity, isolation, distress, and stigma. And I'm going to show you how they actually interact with each other. Again, don't panic if you can't see this diagram. It's probably better that way. The diagram shows you the relationships between the 4 positive determinants highlighted in green and the 4 negative determinants highlighted in orange. You can't see, but I'll highlight here between meaning and quality of life, there is an arrow, beautiful shade of green turning into blue, and the label on that is enhances, because having a sense of meaning in life is a good thing for your quality of life. On the top right-hand side, yeah, wow. Jenny was not wrong that this is a confusing way of doing things. Okay. On the top right-hand side, the orange bubble there is stigma, and you can see that there are orange lines from that leading into a number of the other determinants. Stigma is really bad news for social and material security, for social connectedness, and for distress. On the other hand, there are things that tackle stigma, that reduce stigma, like meaning, like social support, like sense of belonging, and so on. And this diagram is even harder to read. But what we've done here is included the light blue bubbles that reflect the major groupings of the support types that I just showed you. And they include things like peer and community-based services. And not surprisingly, I think, to people in this room, peer and community-based services are connected to almost all of the determinants that I've showed you on this map. By far and away, they have the biggest influence of any of the major social support types. They are one of the only services that actually makes a difference to stigma, because being part of community, being recognised and treated appropriately by a peer is one of the most important ways that we have for helping people to tackle the impact that stigma has upon them personally, and to help them create the social connections that mean stigma is less important and influential upon their quality of life. And this is the W3 diagram. W3 is another acronym, another Graham acronym, short for What Works and Why. That was a project where I was the first project officer way back in 2014. And we used very similar methods to the maps that I've just showed you to locate how peer and community-based programs are situated between the community system, you can see in the green bubble on the left, and the policy and healthcare system situated in the blue bubble on the right. And peer and community organisations are mediating between these systems. So they're in the middle, and they're transmitting the influence from one to the other, and they're translating that influence at the same time, changing it up, translating it so that what we learn from the community system can have an impact on the healthcare and the policy-making system. And I really wanted to emphasise this today because that's a key part of the role of HIV peer navigators. They're an important source of learning about what's happening to the community, and they're an important source of knowledge for the health system about how to provide appropriate care and support to people with HIV. So that's what peer navigators are navigating. Now I want to talk about how they navigate it. And I want to acknowledge here that I'm talking using concepts from Indigenous ways of knowing. That I'm talking about a way of thinking about peer navigation as a story. And I acknowledge, in particular, my own training reflected cultural safety knowledge from New Zealand, but also Indigenous deep history knowledge from the Aboriginal and Torres Strait Islander people of Australia. And this is a very different way from clinical models of care and the referral pathways that we saw earlier with the diagrams that Jenny presented. It is a way of thinking about peer navigation as a story in the life of a person with HIV, but also in the life of a community affected by HIV. And a story has a structure. It is an account of a journey or a process that has a beginning, a middle, and an ending. The peer navigation process is one big story composed of many little stories. So let me start with the big story, the macro narrative, the before, the during, and the after of peer navigation. Peer navigation starts, its first principle is informed consent, the participation of the person with HIV. It includes needs identification. So we might use a tool like POSQUAL as a way of giving us a broad picture of how someone is tracking with their quality of life and what we might want to support them to do. So that's the goal setting aspect. Then the during, what we actually do during peer navigation, there's providing emotional and practical support, which is vital. But a really key aspect of the process is building the skills of that person with HIV to engage in their own healthcare. So peer navigators might go along to an appointment and help advocate with the person with HIV around their health needs. But a kind of crucial part of the process is actually working with that person to understand what their goals are, what happens during the appointment, and then to understand and appreciate the outcomes. And that's the I haven't changed the title here, that should say micro-narrative. But this is the before, the during, and the after of multiple different appointments across the peer navigation client's journey in peer navigation. So the before includes setting goals for care encounters. The during is noting down what happened at the care encounter, and the after is the outcomes and the next steps. So you might go through this process with a client multiple times across their journey in a peer navigation process. And it's those tiny narratives that make up that bigger narrative, that journey towards quality of life. So I'm going to talk now about the essential skills required for peer navigation. These are the training methods. This weekend, I'm going to be running an accelerated version of the synchronous discussions. So normally we have 6 3-hour workshops with HIV peer navigators who are currently working in that role or wanting to work in that role. And these discussions are absolutely vital because it's a chance to have a discussion about values, about lived experience, about the journey that everyone is on, about their reasons for getting involved as peer navigators, about the ethical challenges that come up in the work, the policy, the procedures, the principles and practices that are available to help people navigate those challenges. There's also online self-paced learning because some people learn better on the page. And there are assessment workbooks. There are 4 of those. They take about 2 hours to complete. And they're an opportunity to respond to the materials and to share ethical responses, how you would approach the different challenges. And they let me into that person's learning journey so that I can see, yes, this person is a capable, reflective peer navigation practitioner. The training covers 4 different kinds of work. So there's an introduction that covers HIV core knowledge around things like treatments, prevention, quality of life, health equity. But then we talk to people about 4 different essential skills. And one is the skill of self-work, being able to know your story and which parts of it are tricky to tell and how you might approach that. Client work, being able to connect with someone else's story and engage with them. Organisation work, which is part of the simple fact of life is you've got documentation to complete. You've got case notes to complete. You're providing this enormously emotional and personal service within the context of an organisation, so you need the skills to navigate and negotiate that. And the systems work, and I'm going to talk again about systems here. These are the outcomes. These are some of our first crop of HIV peer navigators. We graduated 26. And they reflected, I'm enormously proud of this fact, they reflected the diversity of the positive communities in Australia. There were trans people, non-binary people, gender fluid people. There were Indigenous participants. There were culturally diverse participants. There were recent migrants, not so recent migrants. There was someone with a PhD, which scared the crap out of me as the trainer, let me tell you. There were trained social workers, ditto. There was just an incredible diversity of experience in the room. So my role as the trainer is not to stand up and say, hey, I know how to do this and I'm going to tell you. My role as the trainer is to lead a conversation where people can share what they already know. So let me conclude in the 5 minutes I have remaining. I want to talk briefly about clinical integration and about learning and advocacy, because these are kind of 2 key aspects where what we are navigating becomes really important. First of all, our goal in the clinic is that we want to see clinicians using POSQUAL. And I actually had the URL to POSQUAL, but I feel like by this point in proceedings, you know what it is. And hopefully it's on your agenda as something you might include in your own practice. We want to see referral pathways from clinic settings to HIV peer navigators for shared care, where clinicians work in partnership with HIV peer navigators to help people with poor quality of life to address the clinical and social barriers that are producing that poor quality of life. NAPWHA is developing a suite of model documents that clinics can use to set up either co-location with HIV peer navigation services, or alternatively to employ their own HIV peer navigators. And I think when we start seeing either one of those two things or both, that's when we know that clinics have really got the memo about quality of life and about the value of the peer approach. And lastly, we're applying for funding to evaluate immediate referral of people who have a new HIV diagnosis to an HIV peer navigator to receive support around that. Because people with HIV tell us, they tell NAPWHA, but they also tell researchers that they first started feeling okay about their diagnosis the first time they spoke to an HIV peer, to someone else living with it who gets it, who understands what they're going through. And then secondly, around learning and advocacy, I'm drawing back here on the findings of the W3 project. Every client encounter is an opportunity to learn about what's happening in the complex community, clinical and policy systems that people are living their lives within. I've shown you the W3 program model on screen before. That's the one with the two bubbles, and the program is intermediating between those two systems. A good manager in an organisation, knowing that it has to engage with those two systems, will seize every opportunity to grasp what peer navigators are learning about those systems and to use what they are learning as a resource for advocacy. To give you an example of this, a really crunchy example that would probably make some managers a little bit uncomfortable, if you're seeing lots of clients who are facing difficulties engaging with a hospital-based service, then you might start investigating. But before you actually go and kind of accuse that hospital-based service of doing anything wrong, you want to get all your ducks in a row. So you would talk to multiple clients, you would talk to other services, you would talk to policymakers, you would talk to researchers to understand the problem before you actually approach that clinic and say, hey, we might have a situation on our hands that we would like you to partner with us in resolving. In the W3 project, we call that packaging, and there's a really crucial role here for organisation managers, leaders, program supervisors, team leaders to play in taking what peer navigation learns about the systems it's engaging with, to package up that knowledge, to make it available to the organisation for use in advocacy within the community. All right, that's enough systems talk. Here are my contact details. The learning platform is available there. If you are interested in training as an HIV peer navigator and you're not coming along to the training that's happening this weekend, it's not too late. You can do the training as a solo learner, and we'll hook you up with a mentor who is someone who has appropriate skills and knowledge, who has some experience in the role, and they will support you through that online learning process. So it's not an entirely solo, boring, click next, 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 done, now I'll do the quiz experience. Thank you all. Any questions?